But all right, instructor for my senior class. I forgot your name, but this is Cody, and this is Sharissa, and they are going to be they're my audience for my presentation. Okay. Hi, I'm Ashley. Thank you guys for coming. So I decided to do my senior capstone on trying to reduce alarm fatigue in the ICU. It's become a major issue throughout the United States. It was actually a Joint Commission safety standard back in 2014. I think they've worked on it to where it's not quite so bad. But I personally experienced this fatigue, like it's actually really very frustrating. It kind of messes with your cognitive process when you're trying to like take care of super sick patients in the ICU, because you're constantly like running to try to fix these alarms and stuff. And one of the references I'll show you later, 95% of the alarms in the ICU were false alarms. So that really can kind of ends up being like very, very frustrating. So let's see here, go on next. That's basically between the introduction and the abstract. And so the big thing is understanding your patient like specific parameters, because the ICU has continuous monitoring because a lot of these patients are really sick, but you have ventilators, ECMO, dialysis, ICP, balloon pumps. And the biggest one that from the research that I did was oxygen saturation monitoring. It's just due to patients moving it, not being placed properly, that kind of stuff. But understanding proper telemetry lead placement, cardiac telemetry lead placement, proper monitoring, how to do it specifically for your patient, because the monitors are not set up specifically for your patient. They are set up for like set parameters, like for, you know, Joe Schmo, anybody that comes off the street. Like 120/80 looks good, but you can set a monitor to their normal blood pressure is 140. You can set that to the high so you don't get an alarm or something like that. But yeah. So let's see here, go on next. So the objectives, basically, I just want you to understand like the importance of reducing false alarms, which I can't harp on enough. Understand the importance of proper monitoring of patient vital signs, because not all alarms are false alarms, but that's the major issue, is trying to figure out what's what. And then understanding like reducing the alarms as it relates to like patient satisfaction too, because that can kind of contribute to ICU delirium and stuff like that. And we really try to keep that from happening, because you're not going to get rest in an ICU as it is, especially in a neuro ICU where I work. So you get neuro checks every hour. So as I said, I work in a neurovascular ICU at Atlanta Medical Center, and already get a lot of alarms because we have EVDs and stuff where we're monitoring, you know, patients' intracranial pressure, which is very important. But you can have these little monitors that go off, and all it is positional, like a patient's moving, and it just kind of keeps going off. So it gets very frustrating when it's not positioned appropriately, or patients are moving and you can't get anybody to help you with it, and then they just end up turning it off, and then it's like, what happens? Right. They could herniate. That's really, you don't want that at all. So let's see. I made it a little funny. I was like, the amount of alarms that can be heard per shift is alarming. But the most frustrating is that a majority of them are false. This leads to the crying wolf. And we've actually had a lot of nurses where they've missed like important alarms. Like one morning, I came in, I was getting a report from the night shift nurses, and the ventilator alarm was going off, and nobody went to check on it because they're like, oh, that patient's ventilator alarm goes off all the time. I have to walk in the room. Their tubing was unhooked, so they weren't getting any oxygen. So I had to go in, put it back on and everything, but that's just how bogged down you get with that kind of stuff. So what I'm hoping is that just to bring awareness on this topic, and just to reduce the number of false alarms like per shift, but more focused on, like to focus more on like the continuous monitoring and the things that we can actually control. Like ventilators are a little different, your ECMO, that kind of stuff's a little bit different, but like the telemetry, the monitor alarms and stuff, we can actually control a lot of that. But you get to where, again, patients move, it gets kind of hard. You don't even think about it because you've got 100 things going on. All right, so let's see, this is just the root cause analysis that we had to do earlier in the semester. And so basically I tied it back to the environment because it's an intensive care unit. You have continuous monitoring, your equipment, and you have to be continuously monitored with cardiac electrodes, your monitors, your pulse ox probes, and then your major staff in the ICU are nurses in respiratory therapy. And those are the ones that have the most control in the ICU over this equipment and your electrodes and stuff like that. Okay, so my PICO question was, what are the most effective methods to reduce alarm fatigue among nurses and prevent false alarms in the ICU? Okay. And so my evidence is following, but I have like 3 major research articles that I used that I looked at for this project. Here we go. The first one was the prevalence of alarms in intensive care units and its relationship with nursing staff levels. And this one wasn't so much they were trying to look at short staffing and excess alarms, so it wasn't super relevant, but the big thing that I brought from this one was that there can be anywhere from 700 to 2,000 alarms in a 12-hour shift, like on this particular 12-bed unit, which is a lot. Like that is an insane amount of alarms. Like we already don't like our alarm clocks in the morning, right? But think about that.
How many of the patients are having to hear?
Yes.
Exactly. That's another big deal.
Theirs plus others.
Yeah, exactly. Like, and the rest of the staff that's in the hallway, anytime you walk in there, and when you leave the hospital, you can kind of hear it.
Of
Like,
course,
ding!
Yes.
the perception of the families is we're not addressing the alarms.
Yes.
Exactly. That's a really great point. I didn't even think about that. But the second article that I used was using pulse oximetry alarms. And this particular unit, what they did for this one was they actually got a doctor to write an order, like for when they could be done with their alarms. Like this doesn't pertain as much to the ICU, but you could have patients that aren't particularly like ICU patients that are getting ready to be like discharged to the floor, transferred off the unit, that kind of stuff, to like discontinue their pulse ox monitoring. But the big thing was that it's that 90 to 100% oxygen saturation. So what they did was, this was the one where they made it specific, like to the patient, where the doctor wrote an order for a specific like number that a patient could be between, like a COPD patient, sleep apnea patients. When they're sleeping, you can let their alarms, like you can actually reduce their oxygen saturation, like alarm limit, so that you're not tinging off all night, because that's normal for them, like they live in that land. But for this particular unit, within a month, they reduced their alarms by 77%, and it had to do with the saturation less than 90%, because that's a big one. Like it's constantly going off.
Wow.
Like that's a big one. And I mean, we get patients with sleep apnea, COPD, especially in this ICU here. There's a lot.
Where 89 and 90 is normal for them.
Yeah, exactly. Or I mean, sometimes I've gotten down as low as like 86. They're tracking, but they're talking to me, they're fine. So it's not, it's really just super specific to the patient on that one. And this last one, this was done in a children's hospital, and this was one where they had 5,300 alarms per day, like on a particular unit, and 95% were false alarms. That is insane. That's way too many false alarms, because you're constantly going, like you said earlier, to address them. And what they did for this one was they developed the plan to change the electrodes daily, make sure they did good skin prep, check the parameters like during shift change, do as like a part of shift bedside report with the nurse, and then just checking the criteria to discontinue monitoring. Like essentially if you're going off the unit, like we're not allowed to do that here and in any other facility that I've been in, especially if they're still in the ICU, you have to keep them on the monitor until they actually are wheeling out. So it's interesting. But so the result of this one was they went from 180 to 40 per day and reduced false alarms down to 50% a day, which is a lot. Like, and that is just basically maintenance, like changing your electrodes and stuff, which don't do a lot of. Like if they don't look bad, usually you don't change it, that kind of stuff. All right. So here, what I'm recommending is that ICU nurses like have to be willing to like get re-educated, like recertified on this, just to make sure that they understand it. I printed out some paperwork here, like for pulse oximetry, blood pressure measurements, common mistakes with blood pressure measurements, and how to properly like prepare someone's skin for like a 5-lead like telemetry placement. And just ensuring that you do these things daily, you're checking on them, checking on your sat probes, understanding like if you have a septic patient that has no perfusion in their finger, they might need to have a forehead probe because your brain's gonna, get more perfused than your fingers. Or you can go to their toes or something like that. But just really it requires diligence on the part of the healthcare staff more than anything with this particular project. But once they're educated is when we could actually start doing measurements, like you could measure before and after. But like I said, in order for it to work, the ICU nurses have to be able to do that. And I think that the alarms would actually go down and the amount of alarm fatigue, you'd have more appropriate alarms. That's obviously the goal of the project, but I think based on the research, there's a lot more research out there. I think this could actually work really well. Because I've even practiced it in my own personal practice, and it makes a huge difference in your day when your alarms aren't going off. Like 100%, like 95% of the time, like that's crazy to me. But like the big thing is like the benefit to the patients. Like you can really miss like a really crucial, vital change in a patient's status when you're not, like if you're like I said, the ventilator before, like not having somebody that needs the ventilator not hooked up to the ventilator and you're just not paying attention to it, it's very dangerous. Like somebody can die that way. Like we actually had to bag a patient back up, like another patient that had popped his ventilator tubing off. We just were like, oh, he does that all night. Had to bag him right back up. Came back up, it was fine, but that's what happens. So I would evaluate the way that I would measure this is measure the amount of alarms before. I'd give it about a month or so before and just kind of get a general idea. And the monitors that we have here and the ones at Atlanta Medical Center, they actually count like all of the alarms that go off throughout the day, like per patient. So you could, and like they always have a set of vitals that come up with it and everything. So what I would do is look at that first, and then while working on staff education, and then just kind of measure it throughout the year, just to kind of get an idea of, like it's to try to hopefully to make sure that it trends down and everything, to see if the education is actually working for them. Let's see, I think that's everything on that. Okay, and like I said, I would expect that it would reduce like the number of false alarms, increase patient satisfaction, that kind of stuff. Let's see, we talked about that. And overall, I think that it serves a great benefit for patients and nurses alike. You already have a lot to do, and then trying to chase alarms that aren't real, and then if something bad happens to your patient, then obviously that's not safe for the patient, but that makes you feel bad too on top of that. So this could kind of help you to feel a little more empowered with like taking care of your patients and stuff like that too. So any questions? All right. Sorry, that was very rushed, nervous, but thank you ladies for coming. I very much appreciate that. Thank you.
Learn something new every day.